Good morning. We are moving into this session on chapter, which covers a phase of disaster management, evaluation methods for assessing public health and medical response to disasters that is often overlooked, but is arguably the most critical for long-term survival. Evaluation methods. When the sirens stop and the dust settles, the physical work might slow down, but the intellectual heavy lifting begins. We have to ask, did our plan actually work? This chapter moves us from the chaos of doing the response to the scientific rigor of measuring the response. Let's start with the fundamental question. Why evaluate at all? Why not just rest and recover? Essential for preparedness. Evaluation is the fuel for future readiness. Without it, we are doomed to repeat the same logistical failures in every single emergency. Objectivity. The core purpose is to assess the response objectively. In high-stress environments, memory is unreliable. We evaluate to move away from anecdotes, like, I felt like we were fast, to empirical evidence, like, we treated 50 patients per hour. Focus. Ultimately, the goal isn't just to write a report. It is to reduce morbidity and mortality in the future. If the evaluation doesn't lead to saved lives next time, it hasn't done its job. But who is responsible for conducting this rigorous assessment? That responsibility usually falls to public health. This brings us to the public health role. In a disaster, public health acts as the auditor of the system. Systematic reviews. We don't just glance at the data, we conduct systematic reviews to look for patterns of failure or success. What we monitor? We use recognized measures to track three things. Processes. Did we follow the protocols? For example, did the decontamination tent go up in 15 minutes as planned? Direct resources. Did the water, antibiotics, and staff actually reach the affected zones? Policy improvement. Crucially, we use this data to inform operational improvements. This creates a feedback loop. The evaluation of today's disaster writes the policy for tomorrow's response. But applying these standard auditing methods in the middle of a catastrophe is uniquely difficult. This leads us to the challenges of evaluation. Scientific versus traditional. Historically, disaster evaluation was traditional, based on war stories and impressions. We are pushing towards scientific evaluation, based on data. But the difficulty is that science requires control, and disasters are chaotic. Unpredictable timing, you can't schedule a hurricane for a time when your research team is ready. Data reliability, in the fog of war, records are often lost or people forget to log their actions. The solution, because of this chaos, we rely on established institutional protocols. We need preset rules that trigger evaluation automatically, ensuring we capture data even when the situation is falling apart. So, despite these difficulties, what are specific benefits we get if we stick to the method? If we employ specific evaluation methods, we can derive order from the chaos. Purpose: the method assesses performance against a standard. Did we meet the benchmark? Benefits: adjust plans. It allows us to tweak the disaster plan before the next event based on real-world friction points. Focus attention. It highlights neglected areas. For example, an evaluation might reveal we are great at trauma care but terrible at mental health support. Refine effectiveness. It forces us to define what success looks like. Is success just survival, or is it a rapid return to normalcy? Research. It turns the disaster site into a learning lab, gathering information systematically from multiple sources rather than just listening to the loudest voice in the room. Now we know the benefits, but what are the specific targets we're aiming for? This brings us to the goals of disaster evaluation. We are aiming for 5 specific targets. Develop profiles. We want to build profiles of victims and injury patterns. Knowing that earthquakes cause specific crush syndromes helps us stock the right equipment next time. Assess adjustments. We measure if our program adjustments, like moving a triage line, actually reduced disability. Identify management methods. We scrutinize the brain of the response, the incident command system. Did the orders flow down effectively? Reduce harm. We identify measures to minimize harm to the community during the recovery. Long-term effects. We look beyond the acute phase to assess the long-term physical and emotional fallout on both victims and responders.
Now that we have our targets, how do we build the roadmap to hit them? We need a structured plan. Here are the key steps. Select measurable objectives. You cannot evaluate doing a good job. You can evaluate response time under 10 minutes. We need concrete metrics. Determine data collection. We must decide how we will get the numbers. Will it be survey forms, GPS data from ambulances, or hospital admission logs? Collect and review. Then, we must have the discipline to systematically collect and review that data, ensuring it is accurate. This sounds straightforward, but a common mistake is waiting until the disaster strikes to start this process. That is too late. Therefore, a critical principle is designing evaluation studies before the disaster. Pre-event design. Structured evaluations should be designed while the sky is blue. When the crisis hits, you should just be executing the plan, not inventing it. What to examine? We design protocols to examine equipment needs. Did the batteries last? Strategies. Was the mass prophylaxis strategy effective? Chain of command. Did everyone know who they reported to? Communication. Was information flowing internally between teams and externally to the public? Once we have the study design, we need to drill down into specific metrics for specific scenarios. Let's apply this to a specific example, defining measures for a mass vaccination site. Review objectives. Our objective might be vaccinate 1,000 people per hour. We identify core outcomes. We break that down into measurable parts. Efficiency. How long are people waiting in line? Communication. Are we effectively communicating with the hearing impaired or non-English speakers? Distribution. Is the cold chain, refrigeration, intact during transport? Measurement methods. We use timestamps on patient forms, logs of vaccine vials used, and interviews with staff. Now that we have defined what to measure, we have to go out into the field and actually get the information. This is the data collection phase, often the most physically demanding part. What to collect? We cast a wide net: medical records, environmental data, weather logs, and social events, crowd behavior reports. The team. This is not a solo job. We deploy a multidisciplinary evaluation team. Physicians check clinical quality, EMS specialists check transport logistics, epidemiologists track disease spread, behavioral scientists track public panic or compliance. Daily debriefings. We conduct daily debriefings to capture fresh data while memories are sharp, rather than waiting until weeks. But where exactly do these experts look for the hard numbers? We look at specific data sources. Hard data, hospital H-codes and EHRs. Electronic health records give us precise injury data. Emergency logs. These track when calls came in and how long response took. Soft data. Interviews. We interview responders, what went wrong, and survivors, did you feel safe? Questionnaires. We use structured surveys for speed and consistency. Abstract. We review medical records abstracts to analyze clinical outcomes. Did patients treated in the field recover faster than those transported immediately? Once we have gathered this mountain of data, how do we organize it into a coherent report? We use a specific framework. When conducting the analysis, we categorize our findings into 5 domains. This structure ensures we don't miss any aspect of the response: structure, process, outcomes, response adequacy, and costs. Let's walk through these 5 domains, starting with the foundation. First, we evaluate structure. Think of this as the anatomy of the response. Focus. We examine the organization and physical resources. Key questions. Were there enough ambulances and ER beds, that is physical capacity? Was the staff sufficiently trained? Human capital. Did the communication radios work and have backup batteries? Technical resilience. Basically, did we have the tools to do the job? But having the tools doesn't mean you use them well. That brings us to the second domain. Second, we evaluate process. Think of this as the physiology, how the anatomy actually functioned. Focus, implementation and workflow. Key questions. Timing. Did the triage teams arrive before the patients overwhelmed the hospital? Coordination. Did the police and fire departments talk to each other, or were they on different radio frequencies? Efficiency. Were workflows smooth, or were there bottlenecks? Adaptability. Did the plan evolve when the situation changed? Example, when the wind shifted. Basically, did the machine run smoothly? A smooth machine is great, but did it actually help anyone? This leads us to the third domain. Third is the most critical domain, outcomes. This is the bottom line. Focus, effectiveness. Key questions. Morbidity or mortality. Did we actually save lives? Health service delivery. Did the hospital stay open and functional? Recovery. How fast did the community get back to work? Community satisfaction. Did the public feel protected? Basically, did our actions make a positive difference? However, making a difference for some people isn't enough. We need to know if we helped everyone. This is the domain of response adequacy. Focus. Equity and matching resources to needs. Key questions. Accessibility. Could everyone get help? Vulnerable groups. Did we reach the elderly, the disabled, or non-English speakers? Quality of care. Was the standard of care maintained despite the volume of patients? Basically, was the response fair and sufficient for the whole population? Finally, we must be accountable for the resources used. The fifth domain is costs. Focus. Financial efficiency and resource allocation. Key questions. Efficiency. Were funds allocated efficiently? That is, paying overtime versus hiring temporary staff. Cost benefit. Were the costs justified by the outcomes? Long term. We consider immediate expenditures versus long-term recovery costs. Sometimes spending more upfront, like better temporary shelters, saves money later, like less medical treatment needed. Basically, was the response financially responsible? Now, let's bring all these concepts together to close the chapter. To summarize this chapter, necessity. Disaster evaluation is not optional paperwork. It is the engine of resilience. Methodology. It requires a structured approach, defining measurable goals, collecting rigorous data, and analyzing across the 5 domains: structure, process, outcomes, response adequacy, and costs. By doing this, we turn a disaster into a lesson. We inform policy, planning, and practice, ensuring that when the next disaster strikes, we are smarter, faster, and more effective.